Esmeda, am I audible?
Yes, sir.
Yeah, okay. Just I wanted to clarify that, sir.
Sir, you can start whenever you want.
Yeah, just 2 minutes, we'll start.
Okay, sir. No issue.
Good evening, sir.
Good evening. Last week, കണ്ടില്ല.
എനിക്കൊരു ഇതുണ്ടായിരുന്നു സാർ, വേറൊരു ടോക്ക് ഉണ്ടായിരുന്നു സാർ അന്ന്.
Okay.
അപ്പൊ കറക്റ്റ് ആ ടൈമിൽ.
Okay, we'll start in just 30 seconds. We'll start.
Okay, sir.
Asmita, shall I start? Okay. Is my screen visible? Is it visible? Yeah, we'll start. Okay. As usual, I will start with a short case first. It's a 23-year-old male. His complaint started 1.5 years back as episodic inversion of the right foot while playing. For the last 1 year, he gave history of tremulousness of both legs while trying to squat, but he could remain in squatting posture only for a few seconds. If he continued to squat, he used to feel a tendency to fall backwards. So before that, he tries to get up by himself. It remained like that till now. He gave history of episodic paresthesia of the right lower limb, radiating from the knee downward to the lateral aspect while sitting for the last 3 months. He decreases on standing position. These are all on leading question. He did not volunteer by himself. Patient also noticed paresthesia of medial aspect of the right arm for the last 1.5 months. No difficulty in putting chappals, no loosening of the chappals. So, history of episodic inversion of the right foot while playing. But he says he never loosened his chappal from his foot, even though he complained that he felt that his feet is going inward. The main complaint was while trying to squat, his legs would tremble, and he could not remain in the squatting position for long. we continue to scat, it tends to fall backward. So that's the story. So examine him. His painless are all normal.
കല്യാണിച്ച് ഈ കണ്ണ് മുറുക്കി അടയ്ക്ക് കണ്ണ് മുറുക്ക മതി, നാക്ക് നീട്ടിക്ക്, നാക്ക് കൊണ്ട് തള്ളിങ്ങനെ കാണിച്ചേ മതി.
Now come to the neck movements are normal.
ഞാൻ പറയുമേ,
The upper limb tone was normal, and also the power was also normal.
മുറുക്കി ഒന്ന് പിടിക്കുക. അതെ, വെരി ഗുഡ്. കൈ ഇങ്ങനെ പൊക്കിക്കേ, കൈ നൂർത്തേ, നൂർത്തി പിടിച്ച് നൂർത്തേ, ഇങ്ങനെ കാണിച്ച സ്പീഡ്.
He had no akinesia, no incoordination. The upper limb. The lower limb, there is no definite spasticity, but left lower limb appears slightly spastic. I am not very sure. That was okay. Left side, it will likely spastic. Again, I am not sure whether he is holding it or not. Power was, however, normal. Dorsiflexion, EXL, plantar flexion, all normal. The reflexes upwards, upper lip, all 1+, just elicitable. Triceps was 2+. Finger flexion was absent. Abdominal reflex is fatigable. It could elicit initially, but repeated doing it, it could not elicit the abdominal reflex. Knee jerks are bilaterally brisk, slightly more brisk on the left side. Ankle jerks are normally elicited or on the brisker side. Plantar was indefinite, neither downgoing nor upgoing. Sensations were all normal. Vibration is also normal. JPS sensation also normal in the upper and lower limb. He said correctly. Coming to the gait, exactly is looking for his passive movements is normal, almost normal. There is no restriction of the spasm on the hamstrings I could make out. Adduction was also normal, no stiffness I could make out. Rhombus is mildly positive, not very convincing, but still is slightly unsteady while closing his eyes. Gait, to me, it's appeared normal. And the walking was normal. He could walk on heel, he could walk on toes. So I made him to squat. I wanted to know what his real problem was. So I held his hand to make him squat. Ask him to keep the heel on the floor. I'm trying to hold it. He's putting weight on my hand. I'm trying to leave the hand. I left the hand, it started to fall backward and got up. So in fact, that is his complaint. So on examinations, cranial nerves normal, tone normal, choreospastic in the left lower limb, not very convincing. AP power normal, TTR 1+ in the upper limb, brisk in the lower limbs. Abdominal reflex easily fatigable in all 4 quadrants, pandas indefinite. Sensations normal, rhombus mildly positive, gait normal. He could not squat without holding on to objects nearby, falls backward when he squats with feet fully on the floor. So what do you think his patient is having?
So can you tell the complaint once again?
His complaint is that when he tries to squat, he feels tremulousness movement of the both feet, and it tends to fall backward. So that's his complaint.
That's for how many years?
That is for, I'll just come back to the history once again. That's a complaint for 1.5 years. Yeah.
Progressive.
No, this remained like that. 1.5 years first notice episodic inversion, then this particular problem. The other things on leading question, he said paresthesia of right lower limb, radiation of right knee downward, and paresthesia middle aspect of the arm. This are on leading question, he said, is got numbness, he said this numbness is there episodically.
Sir, this could be a compressive myelopathy. Could be because there is a compared to the upper limbs, the lower limb reflex are brisk and the plantar is indefinite. And he has certain medial sensory complaints in both upper limbs.
No,
So,
right up.
right upper limb. But there is no definite evidence of myelopathy, but the symptoms, the brisk reflexes and some sensory would point towards a myelopathy. But I think we have to.
Okay, that's in fact. So, any other thoughts?
Weakness, any weakness of hip extensor, sir?
No weakness at all. I could not get any weakness, true weakness at all. He could get up from the squatting, he was tending to fall backward. He could get up by himself. The last video.
While unable to sit up, in this posture is abnormal in myelopathy.
No, this problem is. Yeah, please.
The leg should slightly go forward. Here you find this slightly maybe to squat.
And is it Joy? Joy's voice is breaking. Can you tell once again slowly?
Yeah.
Hmm.
No, while he's squatting, no, his angle should have dorsiflexed much more. This patient.
So what do you think is the problem is?
The ankle contractures, sir.
Plantar flexor weakness, sir. No plantar flexor weakness.
No plantar flexor. He could walk on heel, walk on toes.
Maybe due to
spasm. Okay.
But when
pardon?
When he's trying to squat, he's not keeping his foot on the ground, no, sir.
Correct. He's not keeping his heel on the ground. Once he attempts to keep the heel on the ground, it tends to fall backward.
Could it be extrapyramidal, sir? Some dystonia or something?
But while only on squatting, it comes not present at walking at other times, not there.
So there's most likely a contracture of the Achilles must be. I mean, the tendon must be. I mean, there's a contracture probably due to a long-standing disease, either a LMN or a UMN. But in this context, since the reflex are brisk, this could be a UMN-related contractures.
Okay. Right.
It's a foot dorsiflexion weakness which is not picked up on usual examination.
No, there's no foot dorsiflexion weakness. Normal power.
No, because when he is squatting, he's not able to put the.
No, even in patient
put the heel on the ground and it is fine.
That cannot occur with a dorsiflexion weakness. Even with severe dorsiflexion weakness, patient can do that.
But contractor can prevent the Achilles tendon. Contractor can prevent him from keeping his foot on the ground.
Exactly, correct. But on testing that, they couldn't make out any different contracture with the passively moving it up.
Passive movements, there were no contractures.
Yeah, on lying bed, there is not obvious contraction.
But lateral spastic testing.
Okay, that's good. That's what I got. Let us see what investigation we need.
Fine, sir. MR cervical spine.
Okay, MRI cervical. Because definitely lower limb fluids are undoubtedly brisk compared to the upper limb. Abdominal fluids are also sluggish. Okay. Right. So this is MRI done. It shows a small hyperdensity in the C7 region here. Thoracic cord was normal, lumbar spine was normal. The T1, there is corresponding hypointensity in that area. This is the axial cut. There is small hyperdensity is coming now. I'll show you that. That's a hyperdensity, central hyperintensity. It's C7, C8 region. That is a T1 axial cell, T1 axial. Then dorsal spine axial.
Would that hyperintensity cause spasticity?
That is for us to decide.
How can this pass? Small.
Right. Okay.
More
So this is
settings.
there's a settings there.
What about the brain?
Brain was not done. So what else you need?
Any hip pathology, sir?
Pardon?
Hip pathology, hip region, MRI, pelvis and hip.
Why do you want MRI, pelvis and hip? He has no pain in the region. Fatigue test was negative. I think the suspect
So not
hip joint.
squatting properly, no, sir. There's any problem in the ligaments or that one.
Okay, that's a problem. I agree with you. But hip joint is not going to help us in that. Hip movements are all normal.
So what are the hamstrings? Hamstring, is there any contraction of the hamstrings?
Now, I'll show that video once again. That just go back to the video and show that last part. See this video. I was looking for the contraction, so the video part. While passively extending the knee, extending the hip, showing the adduction, abduction. I was all looking for any contraction. Okay.
Sir,
Yeah.
so what will the hip, the contraction at the level of the hip in the prone position?
No, I did not check the prone position. In the lying position, I do the complete rotation, internal rotation, not everything was normal.
Okay.
You want contraction? Because some contraction is there.
Yes, sir.
That is normal. Then what do you want to do now?
Cervical spine, thin cuts.
Pardon?
Thin cuts.
Yes, dynamic process, sir.
Spastic, yeah, yes, spastic. But gait did not appear to be spastic. Mildly suspicious spasticity, not very convincing.
The sitting was a dynamic because in the lying position, okay.
Yeah, lying position is only it coming. Walking, it is not there. Okay, let us see. So after seeing, in fact, I want to rule out myelopathy, frankly, because of the asymmetric pyramidal sense. But that myelopathy cannot put in this kind of a problem. This kind of problem indicates definitely a tender Achilles contraction. But at the passively examining, I could get the contraction. So what I did, I checked the examination once again. Look at see, making it. Look at the range of dorsiflexion of the angle. Range. See the angle between this is the angle. This is when squatting, the hip down. This is the normal person. Not squatting, this is the angle between this is I am squatting, the degree of dorsiflexion of the hip is occurring. Did you understand what I said? See, this is what Joy said correctly. That is, when you squat, the dorsiflexion should be maximum dorsiflexion of the angle should occur. Even if it is weak, it will passively dorsiflex because of the body weight. Here, what is happening? Unless the knee is bent completely forward, the central gravity will fall behind the malleolus. You have to bring the knee maximum forward so that the trunk and the leg and central gravity should come between the malleolus. If there is a failure of complete dorsiflexion, this cannot occur. Even one angular spot contracture, tendon contracture, this problem will occur because it's not weakness, it's a contracture problem. Now let us see the patient's video once again. I will show once again. See, look at the angle between the forefoot and the leg. See the angle. I am making to put on this. See, now look at the angle now. It should be forward. This is fitting. Okay. So look at this is the angle when the patient is squatting onto the heel is touching the ground. Look at my hand, leg. Okay, his problem was failure of complete dorsiflexion because of the failure of the contracture of the tendon Achilles on asymmetrically on the right side. Okay. I think, did you understand what I meant? What I said?
Why is he developing it now?
Yeah, in fact, so then I sent it to the ortho. Seeing this and sent to the orthopedician to find out any cause. He had an injury earlier in the right angle, which he did not never divulge to me. The orthopedist now he had some bike accident or something. He had got some injury to the knee here, an angle joint much earlier, and that is why he developed contracture later on.
But then why did he develop it on the other side?
No, he has not complained on the other side. It is only on the right side. Even
it's
with
only one side, would he fall? Would he fall backwards?
Yes. In one side he will fall because the angle cannot be made. Even this is unlike weakness. Here, this is a contracture. Unless the dorsiflexion is not, then he cannot squat. The contracture prevent his knee flexion even on one side. That means you cannot bring the buttocks back to the straight to the hip to the angle region.
Can't we squat on one leg?
No, that is that I have not tried. Usually that is not possible, I think. I have not tried that.
Maybe possible.
Squatting on one. Pardon? I couldn't. That is the trick of the case. He reflects your brisk in the lower limb. If he had otherwise, I would not even admitted him.
I just tried, sir. I just tried. We can squat on one leg. It's possible.
Probably trying to squat on both legs. That is, he's trying to fall. You never tried that. So I'll ask him to squat on the leg only on one and left side next time. Okay. So shall I go to the next case?
Yes, maybe with healthy tendency we can. But when there is contracture, it cannot. Maybe.
Yeah, even if one leg.
Healthy with one leg, maybe we can, but contracture means I don't think we can.
Yeah, that's the thing. Okay, now comes the real case. I'll come now. Now, yeah, please.
So, but the main history was episodic tripping of the inversion of foot. How can we explain that?
Yeah, that is not there. Actually, what you said is correct. See, these are the history the people will tell you. Is it walking difficulty? What is happening? Is its angle is going like that? So actually, there is no inversion weakness at all in him. He complains of paresthesia. Actually, nothing. So many of the symptoms, what they said, these people cannot express actually what is their problem. They will come with this kind of a complaints to you. Ultimately, you have to see what which is genuine or not.
Hyperintensity in the cervical region was instructor. Hyperintensity in the cervical cord was just incidental.
That's incidental syndrome, my dear. Incidental syndrome that cannot cause anything.
Sir, HSP can present with TA contracture, no, sir?
Yes, it can. But there is no real spasticity in this patient. You look at the way he's walking.
Sorry, sir, I just got a phone call in between. So what was the diagnosis?
It was a contracture of the tendon Achilles of the right leg. preventing the full dorsiflexion while squatting. So unless the angle is fully dorsiflexed, the trunk cannot be maintained in line with the malleolus. So the central gravity will fall backward, and it tends to fall back.
Thank you.
Okay, I'll go to the good case now. Now, what is this eye movement abnormality? Okay, look very carefully. Just look at the involuntary movement. I think you can skip, but the ocular movements is better. I got two abnormalities.
This side നോക്കൂ ഇടത്തോട്ട് നോക്ക് ഇടത്തോട്ട് നോക്കൂ ഇടത്തോട്ട് നോക്കൂ
Look into the right.
ഈ സൈഡ് നോക്കൂ ഈ സൈഡ് നോക്കൂ
The left.
Very good.
Almost normal.
താഴോട്ട് നോക്കൂ
Looking down.
താഴോട്ട് നോക്കൂ
Hardly any movement.
മേലോട്ട് നോക്കൂ
Looking up. Left eye does not move up at all. Right eye is moving. Okay. I will show this video once again. Then I will show a close-up video.
ഈ സൈഡ് നോക്കൂ ഇടത്തോട്ട് നോക്ക് ഇടത്തോട്ട് നോക്കൂ ഇടത്തോട്ട് നോക്കൂ ഈ സൈഡ് നോക്കൂ ഈ സൈഡ് നോക്കൂ വെരി ഗുഡ് താഴോട്ട് നോക്കൂ താഴോട്ട് നോക്കൂ
He cannot look down.
മേലോട്ട് നോക്കൂ
Looking up, right eye goes up,
മേലോട്ട് നോക്കൂ
left eye does not go up. I'll show the close-up video of this video again. But when it's a close-up, you are it becomes little spongy.
ഈ സൈഡ് നോക്കൂ ഇടത്തോട്ട് നോക്ക് ഇടത്തോട്ട് നോക്കൂ ഇടത്തോട്ട് നോക്കൂ ഈ സൈഡ് നോക്കൂ ഈ സൈഡ് നോക്കൂ വെരി ഗുഡ് താഴോട്ട് നോക്കൂ താഴോട്ട് നോക്കൂ മേലോട്ട് നോക്കൂ
Looking up, right eye goes up.
മേലോട്ട് നോക്കൂ
Okay. What is the abnormality noticed in this patient? Lateral movements were normal. Both eyes were not moving down. When looking up, right eye moves up, left eye does not go up. Lateral movements normal. Any idea or any thoughts?
Vertical one and
Okay, vertical one and perfectly right. But before that, you
Sir, what about the third nuclear third on one side? Nuclear third on the right. So because the adduction is impaired, no?
The adduction part is normal.
Normal, okay. Adduction on both sides normal.
No, the abduction is also normal. Depression is absent. Elevation is restricted on one side, left side.
What about doll's eye movement?
Yeah, correct. In fact, no, this can be due to, as you said, a vertical 1.5 syndrome, or due to a nuclear or infranuclear palsy, or due to muscle involvement itself, manual junction problem. So we don't know what it is in this patient. So in fact, we have to do an oculocephalic reflex or a Bell's phenomenon to show that these muscles are moving, acting, is not moving, and it should be moving in that manner. Then only you can call it a vertical 1.5 syndrome. Because vertical 1.5 syndrome is a supranuclear palsy. Okay. So unfortunately, this was not done in this patient because the patient was not cooperating for that. But it is not my patient. I'll tell you the story later on. Not my patient. This video is sent to me by my doctor, one doctor.
It's not manual junction because it's got that nystagmus towards left side, no?
That part, I'm not touching on that point. That actually had a pendular nystagmus, acquired pendular nystagmus. Forget about that part. So I brought you to mainly to focus on this particular involuntary movement. Presuming that the oculocephalic is intact, what will be a diagnosis? Or Bell's phenomenon is in
1.5 syndrome.
Okay. Vertical 1.5 syndrome. Let us see. Now I'll show another case from the literature, not literature. Look at this one. This is not my case. This is Neurology.
Of my finger. Now
down, 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 down. As far as you can. As far as you can. Go down. Follow my finger.
Here she is looking down. Left eye comes down, right eye does not.
Follow my finger. Follow my finger. Up, up, follow my finger. Up, 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 as far as you can. Very, very, very good. Okay. Follow my finger. Follow my finger, follow my finger. Follow my finger. You see my finger? As far as you can. Further, 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 further. Good.
So I'll show you once again this video part.
Follow the tip of my finger.
On looking up, there is restriction of both eyes upward.
Down, 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 down.
Looking down.
As far as you can. As far as you can.
Right eye does not go down. Left eye is going to see. Right eye is not going down. Left eye is going down. See that?
Follow my finger.
Lateral movements were normal.
Follow the tip of.
So what does he have now? Again, same thing. Okay. It's vertical one because here what is happening is that instead of the down gaze palsy in the previous patient, here the patient got upward gaze palsy. And one eye is not coming down. Okay, again, you have to demonstrate that that eye is moving above ocular capillary. That's a different issue. Presuming that it is there, then you have to think a vertical 1.5. Now, what is the site of lesion for this vertical 1.5 syndrome? How it is produced?
Or mid-brain.
Brain. Descendant.
If you say midbrain, you have to explain why this is occurring, which pathway is occurring.
RIMLF, sir?
Dorsal midbrain.
Okay.
Posterior commissure involvement and down gaze palsy because of RIMLF involvement. Ipsilateral RIMLF.
Perfect. That's correct. That is the answer I wanted. Okay. And what about the other one? What about the patient with the downward gaze palsy and one eye not moving up? That is, your explanation is applicable for the second patient. What about my patient?
Bilateral RIMLF and
bilateral RIMLF means it will result in this thing also. You will get upward gaze also should be restricted by that. Anyway, so it will be difficult, no? So I have drawn the diagrams for you to make it easy understanding. So it will remain in your mind. So let us see the pathway for the vertical gaze. Okay. So this is the red nucleus. This is the RIMLF. For the upward gaze palsy, the fibers go dorsally, cross to the opposite side of the posterior commissure, and supplies the ipsilateral as well as contralateral third nerve. That means muscle required for upward movement will be superior rectus and inferior oblique of both sides. The other side also it goes to opposite supply the vertically upward moving muscles on both sides. So to produce a typical complete upward gaze palsy lesion should be here, because it cuts off the pathway from both RIMLF for upward gaze. But even one-side lesion can also produce upward gaze palsy, but that's only will be transient because the other pathway will take over it. So this is upward gaze pathway. Now see, this is how I drawn in this diagram. This is the three nuclei for the present the third nerve. That is inferior rectus, inferior oblique, superior rectus. I have skipped medial rectus because we are not concerned with the upward movement, upward and downward gaze movement. Now let us see the RIMLF on both sides. The right is on your left. Okay, this is the fourth nucleus. From the RIMLF, it goes to cross to the opposite side of the posterior commissure, supply contralateral as well as ipsilateral inferior oblique and superior rectus. Okay. And the superior rectus is going to supply, recross and supply the contralateral superior rectus. Inferior oblique supplies on the same side, as you can see here. The other superior rectus supply the contralateral superior rectus, inferior oblique on the same side. So, in fact, even if you get one RIMLF stimulated, you get all the vertically moving muscles are activated. Okay, that is the peculiarity of this upward gaze. Same thing will also occur with the upward monologue. Now, let us see the other pathway. This is the same which I already shown. Now, from the left RIMLF, again, the same thing occur, goes to the contralateral side and supply ipsilateral as well as superior rectus and inferior oblique muscle. Okay. Same thing will occur. Okay. So in both will supply, RIML will supply the vertically moving muscles on both sides. Okay. Now, if there is a lesion here, then there will be upward gaze palsy will occur because both pathways are cut down. So to have an enduring upward gaze palsy lesion should be in the posterior commission. Now coming to the downward gaze palsy, see this is the pathway. From the RM, unlike the upward gaze pathway, where the RIMLF is supplying on both sides, here one RIMLF, say right RIMLF, controls downward movement on the same side, ipsilateral side. Okay, that is responsible for the downward movement on the same side, right side. Now, how this is made possible? RIMLF is, as you know, is supplying what are the downward moving muscles? Inferior rectus and superior oblique. So it supplies the ipsilateral inferior rectus and contralateral fourth nerve nucleus. As you know, the contralateral fourth nerve nucleus supplies the contralateral superior oblique. So what will happen? This opposite superior oblique nucleus supplies the ipsilateral superior oblique muscle. Inferior rectus supplies the same side. So ultimately, what is happening? The RIMLF is activating the downward moving extraocular muscles on the same side. Okay, this is because the one pathway is flowing to the opposite side, supply the contralateral superior oblique. So if there is this is responsible for the downward movement of the ipsilateral line. Similarly, on the other side, the left RIMLF supplies the left inferior rectus, cross to the opposite side, and supplies the contralateral superior oblique nucleus, which in turn supplies recross and supplies the superior oblique on the same side, inferior rectus same side. So right RIMLF produces downward movement of the right eye, left RIML produces downward movement of the left eye. So if there is a lesion here, what's the lesion for that? This is the same thing which I have drawn. The lesion is one RIMLF. What will happen? That eye will not move down. But the other eye will move down because the other opposite RIMLF is intact. There is a lesion here, has to be, so to produce a downward gaze palsy, the lesion has to be bilateral or in the central where both the fibers are, the crossing fibers are connected, they are disrupted. Okay, that is a site of lesion of producing the downward gaze palsy. Now, with that in mind, what is the problem in our patient? Let's say one and a half syndrome is upward gaze palsy and monocular supranuclear paralysis, downward movement of one eye. That is our second patient. Or downward gaze palsy with monocular supranuclear paralysis, the upward movement of one eye. Okay. And the vertical VOR or Bell's phenomenon should be known in the sense that you should demonstrate that eye is moving reflexively, either by VOR or by any other means like vestibular or by this thing, caloric test or by Bell's phenomenon. You should demonstrate the eye is moving. That means it's not nuclear or intranuclear. The common type is upward gaze palsy with failure of depression of one eye. The site of lesion, the posterior commissure and RIMLF on one side, the site of monocular downward gaze palsy. Let us see this diagram, how it is producing here. The same thing which I have shown, that's for upward gaze palsy. And the pathway for the right side MLF producing monocular downward gaze palsy. So the lesion should encompass not only the posterior commissure, but also the RIMLF on the same side. Okay. So that is for the upward gaze palsy. There should be lesion for the ipsilateral monocular gaze palsy. Okay. That is one type of vertical 1.5 syndrome. Now come to the second category where the patient has, and this is the same thing which I have shown again in bottom of the one. Downward gaze palsy with monocular upward gaze palsy, what should be the lesion? As told before, this is the pathway for the downward gaze. Lesion should be here, which put a downward gaze palsy. In addition, there should be a monocular supranuclear palsy of one eye, elevation. So let us see this pathway which I drawn before for the upward gaze. So where should be the lesion here? Here. Ultimately, both the pathways are coming just before entering the third nerve. The lesion is occurring there. It means that side will be having a supranuclear palsy or the eyeball movement upward. So that is the site of lesion for this type of vertical 1.5 syndrome, where the patient downward gaze palsy plus one eye is not elevating. Our patient belongs to the second type. Okay, any questions? If you have not understood, I can tell it once again.
The posterior commission has only fibers for upward gaze, no, not for any other.
Yeah, it also carries fibers for this thing, pursuit pathway also it carries. Pursuit pathway as well as the step in, and for the step innervation also it carries through the INC it is connected. INC is connected through the posterior commission. Okay. Because many textbook does not give this explanation of vertical 1.5 syndrome. That is why I thought I will draw myself and show it in this way.
Thank you very much.
Sir, for the downward gaze palsy, if
Yeah.
the lesion is in the center, only this superior obliques will be affected. The inferior rectus, both sides still are innervated. So why can't the patient move down?
No. This is what I showed you. The RIMLF on one side supplies the ipsilateral, inferior rectus, and superior oblique. That is a pathway which I have shown there. I can show it once again. It is not supplying both inferior rectus. This is I'll show this pathway once again. This RIMLF on side supplies inferior rectus on that side. Supplies the contralateral superior oblique nucleus, that nucleus supplying the ipsilateral superior oblique muscle. So ultimately, that RIMLF is going to supply through the inferior rectus muscle and through the superior oblique. So both will put a downward gaze palsy, downward gaze movement. Not gaze movement, one eye movement downward. So in fact, RIMLF is controlling the downward movement only one eye, ipsilateral eye. So to produce downward gaze palsy bilaterally, you have to have conventional downward gaze palsy. The lesion has to be both RIMLF or its connection towards the nucleus like this. There is a lesion here, it will cut off both.
Sir, in this lesion, both the RIMLF can still activate the inferior rectus bilaterally.
Correct. What you said is correct. So the lesion should be that subpart of this fiber. So this for this what I have drawn is for only what you call for diagrammatic representation. So the lesion in the center here can cut off the fibers to inferior rectus as well. That I have not shown here. In fact, the fiber should, this nuclear arrangement is not correct. So this central lesion can also cut off the fibers from the inferior rectus to the inferior rectus, RIMLF to inferior rectus. Here also it can cut off that thing.
Okay. Thank you.
Or that part of the RIMLF, which is destined for the downward movement, it can. That's also there. That is also described. So bilateral RIMLF nucleus can produce part affection can be downward gaze palsy. All the fibers coming from that for the inferior rectus as well as the path. What I have drawn is not correct here. Should have affected the fibers to the inferior rectus also. Okay. For in fact, I have drawn this way only. I have to draw that one. This lesion has to extend out to this pathway also.
So usually, will there be associated internuclear ophthalmoplegia also, sir, in this case? So the midline
no, if it is MLF is also affected, you can internuclear ophthalmoplegia. The part is also affected, yes, of course. The central lesion, there is likely to be involved. It can get involved. It all depends upon whether it's really which part is affected or not.
Okay.
This only diagram represents. Actual thing is, this is I forgot to mention. This is here the fourth nerve fibers will come somewhere below the third nerve. Okay, because it is not lateral as I shown here. So the lesion can involve both the afferent output from the RIMLF to the ipsilateral superior inferior rectus as well as to the fibers to the contralateral superior oblique. That was Which's question. Okay. Shall I go to the next one?
Yes, sir.
Okay.
So what was the patient diagnosis?
Because I only showed the part, I brought this case only for the eye movement. This patient had, in addition, acquired penile nystagmus and has got a lesion earlier in the midbrain. Now he has got some other lesion in the floor of the fourth ventricle also. It's a complicated case. But this is the eye movement. I bought this just for the eye movement. I bought this case too.
Okay, thank you.
Okay, this is a story of a 24-year-old lady. This is a little difficult case, difficult in the sense that problem case for me. She came with a history of intermittent diplopia for the last 5 years, more in the evening. Diplopia is binocular, horizontal, more on looking to either sides. More after reading for some time. No other complaint. So history of intermittent diplopia for the last 5 years, more in the evening. Diplopia is binocular and horizontal, more on looking to either sides. More after reading for some time, no other complaint. So this is the video of the patient. Look very carefully. I was going to look to the left side. Can see movements apparently normal, but some few beats of nystagmus can be seen. There is some restriction of abduction on the left side. Okay. Now I'll show the one more video. A little more clear. Looking to the left side. There is some restriction on the abduction. Here also seems some restriction of abduction. And few beats of jag nystagmus. Upward movement normal.
Is there ptosis on left side, right side?
No ptosis. But you can see the few beats of nystagmus when looking in either direction. Okay, other movements were all normal. So there was other rest of the cranial examination normal, orbicularis, occiput normal, rest of motor system normal. So there was a restriction of abduction and there was nystagmus in both eyes on extreme case. Rest of the ocular muscles normal. So first question, which is the affected muscle? Right lateral rectus, left lateral rectus, or both?
Both.
Should be both because it's got bilateral.
Okay, both. Okay. Let's see. This is so. This obviously left is appears to be weak. Okay. And Here right appears to be weak, correct? Okay.
Right movement is not full.
Pardon?
Right movement is not full. Abduction.
See, you can, there's some disconjugation. No, you see, left eye is little gone in compared to the right.
Yeah.
That maybe because the right, maybe right lateral rectus is weak. Okay, everyone agrees with that?
Yes, sir.
May not be, maybe inhibitional palsy.
Correct. This can be on to keep the possibility of inhibitional palsy. Suppose he has got left lateral weakness alone in this patient. You can have a apparent deviation like this when the patient moves to the right side. What is this inhibitional palsy? That suppose he has got a left lateral, imagine the patient only left lateral rectus is weak. Okay. On looking to the right side, the left medial rectus is an advantage because left lateral, the antagonist is weak. So it is easily adduct the eye onto the left medial rectus can adduct the eye. Because left lateral rectus is weak, it leaves less innervation for an adduction. Only that much of amount of innervation goes to the right contralateral lateral rectus, that is a paired yoke muscle. So right abduction will be apparently weak. So it may looks like a bilateral lateral rectus.
What about
that is
abduction
called
movement?
the inhibitional pulse. I'll come to that. Just one by one. Okay. Each step I'll show you. So this first is I have to decide whether it's actually a bilateral lateral rectus weakness or only lateral rectus weakness on one side with inhibitional pulse on the other. Okay. That has to be decided first. So what test will you do?
Duction movement.
Uniocular movements.
No, duction movement. See,
yeah, you want with one eye closed.
In the other closed. Yeah, uniocular.
Yeah,
with
because
the left
if
eye closed.
No, I'll tell you, if there is do a duction movement, possible you can find out whether there is a restriction is corrected or not correct. But in a mild lateral rectus weakness, it can be missed in duction movement. Because patient may put a ball effort to look at that, it will be overcome. Be little difficult. But that answer is correct, that can be used, but which is the ideal test to do that?
Primary and secondary deviation, sir.
No, that's for paralytic and concomitant skin. Here, what you have to do is the cover uncover test. We will know which eye is fixing. Okay. Now do the cover uncover test. Now look at very carefully. I'm going to each crossing each eye alternatively. He said two.
Okay.
This is two again. It is also double, but mildly less. Let us see what is happening. I close the left eye, nothing is happening to the right eye. Close the right eye, left eye abducts. I will stop here. Now, what did you observe now? Before going to the rest of the video.
Movement of the left eye.
Yeah, the deviating eye is the left eye. The good eye is the right eye. So right eye is fixing onto the target on looking to the right side, even on looking to the right side. So it's unlikely to be a right lateral rectus weakness. Okay, that is point number one. Let's come to that. Now let us show the subsequent video. Looking to the left side. The left eye deviates. Closing left eye does not deviate. That means the good eye is on the right side. So even on looking to the left side, the one which recorrects on closing the right eye is the left eye. In all the whether to look to the right side or left side, the eye which fixes on that object is the right eye. So he has got actually a left lateral rectus weakness. You understood what I said? Please,
can you say it once more, sir?
Yeah, I'll tell you once again. See, Now look at this position now. I'm asking him to close.
ഇപ്പം കാണുന്നുണ്ടല്ലോ.
രണ്ടായിട്ടുണ്ട്.
നീ അവിടെ നോക്കിക്കൊണ്ടിരിക്കേ, കണ്ണ് മാറ്റല്ലേ.
Right eye is not moving, not moving.
അവിടെ തന്നെ നോക്കണേ.
Okay.
മാറ്റല്ലേ.
The left eye is deviated. See, his deviation is corrected. That means that the left eye has gone inside unnecessarily. The right eye is fixing at the object, left eye has gone inside. That is why, because the left lateral rectus is weak. Left lateral is overacting. When I close the right eye, left eye is forced to look at my finger, so it is coming back to look at my finger. Okay, that is the first part. Now let us do the second part. He is coming back. Now go to the second part. I'm going to left side. I want to know the right eye is left. See, I close the right eye, left eye is fixing. Otherwise, if close the left eye, right eye is nothing is happening to the right eye. So when you do the cover, when you, irrespective of which eye is closed, the right eye is fixing. Okay, irrespective of which position it is, right eye is fixing. That means that is a good eye in this patient. The deviating eye is the left eye, and the deviation is towards the adduction position. That means the abduction is weak. Even in the lateral position also, you see what is happening. It is going out. That means it has gone inside because of the weakness of the lateral rectus. So we're trying to fix out the other side, it goes outward. Okay, is it clear now?
But patient is also.
How does it
having
prove that the right
diplopia.
lateral rectus is not weak?
No, and the current position is right lateral rectus is normal, because when he is fixing with the asked to fix with the left eye, the right eye is sorry. When you close the right eye and then asked to fix the left eye, the right eye is not deviating. It goes on fixing onto the right object itself. That means the right eye is normal.
This patient was complaining of diplopia even when she was looking forward, no?
Yeah,
even
forward
when she was
also.
looking forward, she was complaining.
Correct.
How does that happen?
Yeah, because that is because of the overaction of the left eye. It has gone medially. Some time back, I had shown one case, no, when the patient has got, when there's a long-standing deviation, they can go to extreme position. You remember one pair going downward.
Yes, yes.
Okay. Okay, let us now.
Stories. Spread of.
Pardon?
A spread of committance is it that or something else?
Yeah. The long-standing case becomes spread of committance. The deviation will remain equal through all directions of gaze. It will be the deviation will be maintained. This is because of the antagonist overaction.
Is that the case here? What's happening here in this patient? Or
yeah, most likely so. But the story does not end here. I'll come to that later. It could be that way. It can be long-standing one-sided paralysis can mimic a bilateral arthritis. Because in all looking direction, that separation, that discontinuity will be maintained even on looking to the opposite side because of the spread of competence. Okay. There to find out which is the good eye or bad eye, you have to look at this cover uncover test is the one method to choose. Okay, left laterals is weak. See, on looking to the left on binocular viewing, the right eye was fixing, left lateral rectus was underacting due to the weakness of the left lateral. That's what I showed here. The second part. Looking to the right on binocular viewing, again the right eye was fixing, and the left middle rectus was overacting, goes into the adduction position because of the weakness of the left lateral rectus. That is why when you cover the right eye, the eye goes from the adducted position, left eye goes from the adducted position, little more to the primary, to little more to the fixing position. So now, what is the diagnosis now? So we now know that he has got a lateral rectus weakness, asymmetrically for 5 years, producing diplopia.
On the left side.
Weakness apparently on the left side. What is the likely etiology? Could be myasthenia.
Five years and could
5
be
years only lateral rectus alone, like this, sir.
could be a manifest latent squint or something.
Okay, left esophagus has become esotropia. That's a thing like this. The two possibilities one you have to keep in mind. But what test will you do to differentiate these two things? You can do duction testing. Okay, because in duction testing, what will happen in manifest latent squint? It will be perfectly normal. Okay, whereas in the case of my weakness due to any condition, that will be manifest. So this is the duction testing. There is no update, but if some few jerks of nystagmus happen even at closing one eye. But there's some sclera is visible on the even on looking maximal to the left side, but grossly normal. So what do you think? Is it a manifest latent squint or a weakness of the lateral rectus?
Even if it's a manifest latent squint, the sclera can be visible, no? Because it's only manifest.
No. It manifest latent squint means it will be full duction, will be entirely normal. Because
then what is manifest?
Pardon?
Then what do you mean by this manifest?
Manifest squint is when the patient is asked to look bilateral and only on binocular viewing, this problem will come. Because why this manifest latent squint is occurring is because your fusional virgin system breaks down. The fusional virgin system is operating only for binocular viewing. With monocular viewing, there's no problem. The subtle weakness is that subtle weakness will not be when you close away, that is overcome. The brain can activate that muscle and can move in any direction. So here,
this is paralysis.
Yeah. So apparently there was full ocular movements suggesting that non-paralytic squint or manifest latent squint. But there is some suspicion of a mild restriction of abduction on the left. Did you also think there's mild restriction on duction movement? Yeah. Yes, but overall it's difficult. That's what I initially said. Duction movement, mild weakness can be easily missed. But the major point is that there is nystagmus of the left eye and adduction, even on the right eye. So that will not occur with a manifest latent squint. Because this type of nystagmus is due to what? Due to the fatigue of the extraocular muscle. That is required only when there is a real weakness of the muscle.
But some amount of nystagmus jerk can happen in extreme gaze, no?
Yeah, that can occur. That can occur. But that can occur. That's not against. But how often do you see this in this context? It's not like a few jerk nystagmus. It's asking, going on, looking at that is just come. That means she's putting an effort to contract that muscle. That is the point we have to keep in mind. So nystagmus make you suspect that that's real muscle weakness per se rather than an inherent, old manifest latent squint in this patient. Anyway, there is one point. The problem is duction testing may not pick up mild paralytic because extraocular muscle. It also may not pick up intermittent weakness, obviously. So, what do you think now? You want to think of some real weakness of the muscle. Very unlikely, because the fatigue nystagmus. Manifest latent squint will not produce nystagmus due to fatigue and attempting to move in the restricted direction on duction testing. Because the reason which I already told you, because the fusional mechanism will not operate for a uninucleotide. So already investigations ruled out myasthenia was planned. But she was already seen elsewhere and fully investigated. ACH antibody was negative. RNS done outside was normal. CT chest was normal. This is a CT chest. The patient came with. There is no thymoma. So what do you want now?
MRI brain.
Pardon? MRI brain. Did I show the MRI? Okay. Okay, MRI. She has already had MRI brain with her. This is the MRI brain. Tactile region normal.
Orbit.
MRI orbit, this is the orbit. Again, grossly, this is the MRI brought by the patient, but not a good quality, but still the orbit shape is normal. What do you do now?
ISPAC test.
Therapeutic test.
Right. Your therapeutic trial with medication? Or you want some more test?
Fundoscopy.
Neostigmine IV, you want, sir? Neostigmine.
Okay, correct. So they pay whether you try to empirical treatment with anti-myasthenia. So far the tests were all negative for myasthenia. But she was already on treatment with pyridostigmine Asurant for the last 6 months. By the time she came to me, there was no response.
Then it is not myasthenia, no, sir.
No, how can you say it's not myasthenia? Lack of response does not mean it's not myasthenia.
External antibody profile for myasthenia.
Yeah, so you have to do. So SHR antibody was negative. So I did ISPAC test to be confirmed. I have to confirm it is myasthenia or not. No. So I did ISPAC test. That was negative. There is no improvement with ISPAC test. What next?
Fiber EMG.
That is not done. I have not done it.
RNS.
The next thing is to find out whether some kind of a restrictive ophthalmopathy, like advanced retraction syndrome, mild form, which restricts abduction. That you have to keep in mind. Okay. So what will you do now? To rule out restrictive ophthalmopathy.
Force reduction test.
Okay, force reduction test was done. There is no restriction. Obtain the possible acute comitant esotropia cause. This is her report. Unlikely to be advanced as it is acquired, and there is no restriction of ocular movement. Fox reduction test was negative. Now, what will you do now?
Musk was done, sir. Musk.
Okay. So before that, we have to neostigmine test, no? That's the thing we have to do. Nobody has ever done neostigmine. So previously I was shown, no, all tests may be negative. Neostigmine may turn out to be positive. So I did, this is, look at the videos very carefully. This is before IV neostigmine 1 milligram. This is the video. This is the pre-neostigmine, mild restriction of abduction, few beats of nystagmus. Now, 3 minutes after neostigmine, the weakness has appeared now bilaterally. Nystagmus has worsened. She cannot abduct bilaterally. Is worsened. The weakness is worsened. She is complaining also worsening of diplopia. Then 4 minutes after neostigmine, she complained of difficulty in swallowing saliva. Wait. Gross restriction, bilaterally restricted, and even the adduction movement is also restricted. See, did you see that? Not only that, abduction also is slow. See, it's also become slow now. So 5 minutes later,
Sir, is there any fasciculation of the tongue at this time?
Fasciculation. No, all other things are normal.
Then it's a non-organic.
Let us see. Let's see.
ഉള്ളോട്ട് നോക്ക് മോളെ, ഇങ്ങോട്ട് നോക്കിക്കേ, അറ്റം നോക്ക്, അറ്റം നോക്ക്, ഇടത്തോട്ട്, ഇടത്തോട്ട്, മുകളില്, താഴെ.
Then, so after neurostigmine, extraocular muscle weakness worsened. She developed weakness of both medial and lateral rectus, maximum for the left lateral rectus. Moreover, she developed mild pharyngeal weakness after neurostigmine. So what will you do now?
Anti-musk antibody.
Pardon? Anti-musk antibody. Okay. No, before that, I wanted to be sure that is the manifest statements has to be excluded totally. So whether that subtle manifest statements can worsen with neurostigmine, I do not know. So I did to be certain, absolutely certain. I did that duction movement when the patient had real weakness. So I did duction testing to find out whether there is real weakness of abduction or was it a manifest statement skin. It's very unlikely, but I still did that because the ophthalmologist opined that possibility.
ഇങ്ങോട്ട് നോക്കുമ്പോളെ, ഇടത്തോട്ട്, ശരി, ഇനി ഒരു കണ്ണടച്ചോ.
On closing, it's not going at all. See the original one and this one.
നോക്കുമ്പോളെ, ഇടത്തോട്ട്,
gross restriction of abduction.
താഴെ, മുകളില്, ശരി.
Here also there is abduction.
ഇടത്തോട്ട്, വലത്തോട്ട്, ഇങ്ങോട്ട് നോക്ക്, ഇങ്ങോട്ട് നോക്ക്, ഇടത്തോട്ട്, വലത്തോട്ട്, താഴെ, മുകളില്, ശരി.
So that
ഒന്നുകൂടെ, ഇടത്തോട്ട്, ഈ വശത്തോട്ട്.
So that conclusively tells you it is not a manual latency. No need to send to the ophthalmologist for any correction. There is real weakness of the muscle. Individual muscle is weak. So it's not a case of manifest statement skin. Circular muscle got worse than neurostigmine. Now this is 10 minutes after neurostigmine. He is improved. And the neurostigmine effect waned off. The discharge has improved. But still not the peak. 30 minutes after that, she became to the original state. Mild lateral rectus weakness.
ഇപ്പം ഇഞ്ചക്ഷൻ കഴിഞ്ഞിട്ട് ഇപ്പൊ 2 മണിക്കൂറായി അല്ലേ? ഇവിടെ നോക്കുമ്പോളെ,
she came back to the original states. So what will you do? So what are the situations where neurostigmine can worsen the weakness?
Congenital
syndrome.
Okay. Okay. Congenital crisis, of course. Then, but here there is no question of congenital
syndrome.
Which myasthenic syndrome can worsen?
Slow channel.
Slow channel as well as acetylcholinesterase deficiency. And okay, and as Butch was telling, musk myasthenia. Musk myasthenia can also worsen sometimes with neurostigmine. So what will you do to rule out slow channel syndrome and acetylcholinesterase deficiency?
RNST, sir. Repeat RNST.
RNST. RNST or
CMAP.
CMAP.
Double.
Okay. Okay, double map. So this is and musk antibody. These are things you have to do. So this is the from literature. Pyridostigmine prolongs the action of acetylcholine upon posterior receptors through inhibiting the synaptic clustering, so that you all know. And pyridostigmine may not be effective or even result in deterioration in neuromuscular transmission in musk positive and myasthenic gravis. Okay, this I will skip. Okay, repetitive CMAP. This is a repetitive CMAP. This is right ulnar. There is some speak there. This is the left ulnar. Left median. So is there a double CMAP?
No, sir. No.
No, so it's not very convincing. It's not a simple. Also, this is another patient which I had presented earlier who had a slow channel syndrome. This is the double CMAP, but this is different from what I got. got it there. But I'm not totally against that possibility, but doesn't look like a double CMAP. So what I did, I repeat the same test on the affected muscle, facial muscle. That is near the orbicularis oculi. This is from the looking for the repeat CMAP. Again, there is no repeat CMAP, the facial, upper facial muscle. Okay, what else you want to do? Anti-musk antibody?
Yes, sir.
Negative.
Can do a genetic testing.
Genetic study.
Okay.
Genome sequencing.
Okay. See, all these tests I have done with the help of my money because she could not afford anything. If you say genetic test, I will do all these OPDs. I am seeing free consultation for because I wanted to prove what this patient is having. So she cannot afford anything. She's a very from the poor family. So I put the patient on salbutamol because I'm sure there's some kind of neuromuscular problem. Because otherwise, if you don't have worsened with NAMIs, they have an aneurystic. All other things should have improved. What neuromuscular problem, we don't know. Ideally, the patient should undergo genetic testing, but she cannot afford that. And the previous periodostigma previously, there's no question of putting on periodostigma because it's going to worsen. The only other thing is, are we dealing with some kind of a condition similar to slow channel or something like that? So I put the patient on salbutamol. And 2 weeks later, I has to come back. She said only mild improvement, but she developed tremor on salbutamol. So she stopped coming to say I got severe tremor. So I did not leave that on that. I doubled the dose of salbutamol and put propranolol to control the tremor. Because I want to show that this patient is either responding or not responding to salbutamol. She came back after 3 weeks. There was no improvement. She says, absolutely no improvement. I stopped salbutamol. What will you do?
Fluoxetine, sir.
Fluoxetine is salbutamol is the ideal thing. Very unlikely to respond. I do not know. They put the patient. Okay, I put the patient on steroid and send the patient because she was not tried. She was tried on initially on pyridostigmine and azoran and steroid for a short course only. So I put her on relatively high dose of steroid and that come for follow-up. I do not know whether she responded or not. I do not know the diagnosis. The only things I can know is that it's a neuromuscular problem. It's an acquired neuromuscular problem. Now, I brought this case because how we could go through the various tests at each step, starting from the cover-uncover test to find which side is affected. Then for the each investigations to come out to the arrive at that diagnosis. Any thoughts, any idea from anyone?
Just like this mask thing, you have got something called agirin or something, no?
Agrin and LPP for all the extended.
Yeah. Body, these are
And
all things.
Raynaudism.
There are something like that. So I thought I will try a steroid. I'm not sure this respond or not, but there's a thing. Agrin, LRP4, these are other anti-titin, these are all can produce myasthenic syndromes.
The ryanodine receptor antibody.
And ryanodine receptor antibody, that produce myasthenic syndrome like that.
Yes, sir. Extended spectrum. Dr. Sudhiran is doing.
Okay. That okay, shall we stop?
Malignant hyperthermia, no? And your ryanodine receptor.
Extended spectrum, it is there.
Yeah, maybe that I would look into that. I'm not very sure. Okay, shall we stop here?
Can I short case, sir?
Short case is not there, only long case is there. So let me check whether I got a short case. I can.
Sir, one doubt, sir. Sir,
Yes, Bindu, I couldn't hear
Sir.
you.
sir, one doubt, sir. Sir, if the patient like this case, if the patient is not responding to treatment,
Yeah.
can we go ahead with the steroids and acetylcholine and all, like almost all the negative, all the tests for the classical test are negative. But can we go ahead with the trial of like the steroids and
Yeah, that's what I tried. That's what I tried. We know
Okay.
it's a background problem, not a manifested
Oh.
spin. It's a neuromuscular problem. We all know that. But what we do not know. So since then, could not detect any antibody, does not rule out the possibility of an immune-mediated disease. As you said, and Joy and all people telling about the various other conditions like gangrene and things like that. So that possibility has to be kept in mind.
and suppose the patient response, are we justified in continuing with that?
Yes, definitely. Definitely,
sir.
we have to continue. I'll show you a ultra short case. Okay. Story of a 12-year-old girl is born normally, but has noticed a delay in milestones with the normal cognitive milestones. Sorry, delay in motor milestones with the normal cognitive milestones. Since the time child started walking, she was noticed a pain in the calf while walking and noticed how her feet get inverted while walking, which remained like that since then. Sorry, I did not edit my grammatical errors. History of cramps affecting both the lower limbs. So problem is delay in motor milestones with inversion of the feet while walking and cramps. This is the video of the patient. It's got spasticity of the lower limb.
काल में लेती सीधा
Power is proximus is normal. Knee extension normal. Look at the feet. Dorsiflexion is normal. Plantar flexion normal. That was weak. Adduction was weak. And there is contracture of the tendon Achilles. Abduction was normal. Adduction was normal. Upper limb reflex is normal. Dejects were brisk. Angle check. Scotippus cavus. Angle check was absent. It is not brisk. What is characteristic? The adduction is contracting. The foot is not plantar flexing.
See that. Adduction is not, angle is not contracting.
Plantar is not flexor. Sensation is normal.
Vibration. 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 Now. Now. Now.
Made mistakes in the JPS.
Mom. No. No. Sure.
ನಡೀರಿ ನಾರ್ಮಲ್ ನಡೀರಿ
She cannot fully dorsiflex. Even the power appeared normal. You could walk on, you can walk on toes. I could make a fast.
Bunny.
Okay. Examination, high milk was normal, caneless normal, motor upper limb tone power normal, lower limb contracture the tend to Achilles, spasticity of both the lower limb, power normal except for the EH and adductor hallucis. DTR normal in the upper limb, lower limb, knee jerk, brisk bilaterally, absent angle jerk grossly diminished. Adductor jerks on doing both angle jerk. Adductor contraction is occurring on doing the angle jerk. Abdominal press intact, plantar indefinite, sensory normal. Cannot walk on heel, can walk on toes, and that's a gait which is solved. So what is the diagnosis?
Third cord syndrome, spinal.
Okay.
With the, they can be associated skeletal thing, like pes cavus and all, because spina bifida, occulta, all those kind. Because upper limb is normal.
Correct. So that's one possibility you have to keep in mind. I agree with you. Then only but absolutely no sensory in this patient. No bladder problems, no sensory.
HSV plus,
sir. Pardon?
HSV plus syndrome.
HSV plus, agreed, or
HMS and
there are two conditions can mimic like that. One is HMS and type 5 because of the pes cavus and absent angle jerk and the classical wasting of the interosseous. Or it could be HSP plus, HSP with peripheral neuropathy. These are the two things you have to keep in mind. So, as Bindu was telling, we could give the possibility of spina bifida to be ruled out because there is a treatable condition. There is no spina bifida in this patient. So, NCV was done. I'll go to the positive findings. See, this is NCV. I was just trying to find out where is abnormality. Latency. This is okay. Yes. Now I'll come to that. Well, this case which has seen long back, I forgot the values. So NCV velocity was normal. I'll go to the median. That's also normal. Upper limbs are normal. Lower limb, again normal. Sensory, normal. FA, normal. So sensory and NC studies closely normal. So what is the diagnosis?
Sorry, in one of the videos, is there any striatal toes?
Striatal toe, no, there's no striatal toe. The possibility still remain the same. It does not exclude either possibility. It can be most likely to be an axonal type of HSP plus, or it may be HSM and axonal type, where the abnormality may be only confined to the distal small muscles of the feet. But we cannot prove by this one. MRA brain, I don't know, it was done.
Because if it is HSP plus, there can be thin corpus callosum.
Yeah, correct. There's one variety, like correct. So these are the two possibilities you have to keep: HSP plus versus HMS in type 5. Okay.
Okay, sir.
Okay, good night. Thank you.
Sir. Thank you, sir.
Thank you.
Good night.
Good night, sir.
Good night. Good night. Thank you.
Thank you, sir. Thank you.
Thank you. Thank you.